Take a look. What medication is used to abort a migraine headache? What's the key word in this question? Abort, exactly. The class of medications that we use to abort migraine headaches are the triptans. So look at number 1, sumatriptan. Yes, that's your best answer. But while we're on this question, what is number 2 and number 3 and number 4? What are those other meds called? Prophylactic meds. What does that mean? It's a drug you take every day in hopes that you will have fewer headaches, and when you get one, it won't be as bad. That's what a prophylactic med is. It doesn't mean you won't ever get a headache again. Look at my next question. Which female patient with a history of migraine headaches would be the best candidate for combined oral contraception? Whoa, big deal. Migraineurs tend to be female, 5-2. In the 5-2 ratio, women are more likely to have migraines. And you know what age they are? Childbearing. So combined oral contraceptives are a big deal in this age group, in this population. There is something you always must ask about, because it is always a contraindication to combined oral contraceptives in these women. And it is someone who has what? Aura, right? So take a look. The question says, which female patient with history of migraine headaches would be the best candidate for combined oral contraception? It's someone, look at number 2. She's a good age, 25, no auras. She would be a good choice for a combined oral contraceptive. A 25-year-old with aura, any year-old with aura, you need another choice, right? Not combined oral contraceptives. You need something else. Age 40, too old. What's the cutoff? Probably around 35, all right? So what's the best answer? Best candidate? 25-year-old migraine, no aura. Everybody with me? That is a huge safety issue, and I think you'll see that again on your exam. Everybody with me? All right, let's keep going. Prophylaxis. I told you that we use prophylactic meds, and here's why we do it. Because if you overuse a medication, it doesn't work so well anymore. The pharmacologic term we use is tachyphylaxis. It means you use the drug over and over again, and now it doesn't work. That's what happens with nitroglycerin. That's why we have those 12-hour nitrate-free periods. That's why we don't want people to use albuterol more than twice a week. Because if you overuse it, it doesn't work anymore. That happens with the triptans. So here's your level of tolerance. If they have more than 2 uses per month of triptans, you've got to be thinking prophylaxis. Because if they continue to use an abortive agent, it is not going to work for them. All right? So that's a concept I want you to take home with regard to prophylaxis. Migraine headaches, you'll see loads of them. When we talk about the most common headaches that you encounter in primary care, there are 3 that we typically talk about. Obviously, migraine headaches, tension headaches, and cluster headaches. Cluster headaches are probably the least common, but let me make sure you know about headaches. Let me tell you a quick little story about myself. My background in nursing had been in critical care. The sicker they were, the better I liked them. My perspective was always that when people came into the critical care unit and they had headache, they usually ended up with a craniotomy. They did. They had a tumor, they had a bleed, they had something. They had a closed head injury, So headache to me meant craniotomy. So here I am, I'm moving from critical care into primary care. I probably saw 5 headaches a day. I couldn't even get imaging studies on them. And all I kept thinking about is, oh my God, craniotomy. I couldn't even get a CT on them. So I ran into a friend of mine who's a neurologist. Like I was probably 6 months out of a brand new NP, 6 months out. He said, Amelie, how you doing? I said, oh, terrible. He said, what's the matter? I said, I don't think I've slept since I became an NP. He said, why not? I said, I'm so worried about all these headache people I'm seeing. I said, they probably all need craniotomies. I said, I'm so worried I'm not sleeping at night about them. He said, let me tell you what you need to do. And I want to pass this on to you so you can sleep better at nighttime. He said, Amelie, if you will ask your patient with a headache these 5 questions and document the response, you'll always know who needs an imaging study, who needs to be worried about, and you'll sleep better at night. I'm like, lay it on me. This is what I want you to do. He said, when a patient comes in with a headache, you always ask them, where in their head does it hurt? Look, location. The second question you ask them is about the characteristics of their headache. Does it throb or pound? Is it a crescendo headache? Meaning it starts very soft and then it's subtle and then it gets worse and worse over time. For me, one of the most valuable is what my patient looks like. What's the patient appearance? If I go into an exam room, I knock on the door, the light is out, and the patient's in a fetal position on the exam table, that's a very different headache than when I walk into an exam room, the light is on, and they're reading their iPad waiting for me to come in. Patient appearance is a huge clue to you about the severity of your patient's headache. The duration with regard to migraine headaches is the best question you can ask, because a classic migraine lasts less than 3 days. If somebody comes in to see you and says, I've been having this headache, I don't know, it's between like a 3 and a 5. I've been taking Advil and Tylenol, nothing makes it get better. I've been having this headache for probably a week and a half. Like, I feel like I've been gut punched, because that's not a good headache. How long the patient has had a headache should be a huge red flag for you. And then finally, what else is going on with the headache? Oh, you have phonophobia. And you have that. Looks like you got a migraine headache. So then this is what he told me to do. He said, you ask and document the answers to those 5 questions. He said, now you look at what you documented. If what you documented looks like this, he said, they got a migraine headache. The person who needs imaging is somebody who has 2 of these, 1 of these, 1 of these, and 2 that are not even on his list. That's who gets an imaging study. I got it. Okay, I got it. Now I sleep better at night, and maybe you will too. All right? Those 5 questions are key when you are trying to figure out what kind of headache a patient's got. So that's one chart I made for you that ought to be helpful. The other chart that I made was just kind of another quick one. I think you'll see these in primary care, and maybe you'll see them on the exam. It's just a quick, here's the symptom, and here's what you ought to consider for your differential. Obviously, with nasal stuffiness and a headache, I'm thinking about sinusitis. But there are 2 I want you to put a star by. I want you to put a star by temporal arteritis that famously appears on the exam. And the other one that I want you to put a star by is pseudotumor. The last one, pseudotumor. Put a star by it. Maybe you'll see that again. And so look at your patient. You're in your first week of clinical practice, and here's how it goes. A 20-year-old college student was in class this morning and described sensations of bright lines in both eyes when she looked at the screen in front of the classroom. This lasted for about 30 minutes and then it resolved. She came directly to the Student Health Center and the NP is evaluating her. That's you. She states that she feels nauseated and has a pounding headache, 6 to 7 out of 10, above her right eyebrow. This started about 20 minutes after the bright lines. She feels very scared because this has never happened to her before. She denies drug use, but admits to alcohol use about 3 days ago. Her neuro exam is normal, but she's photophobic. My question is, what's at the top of your differential? Migraine with aura, right? Migraine with aura is at the top of your differential. So let me just kind of ask you this. And what you can do is circle or underline the answers to these questions. Look. What historical information or findings on physical exam make you think migraine? Well, kind of like her age. All right, she's 20. Bright lines in both eyes, I'm thinking that's an aura. Lasted about 30 minutes and then it went away. I'm thinking that's an aura. She feels nauseated, common with migraine headaches. She has a pounding headache. Pounding, a throbbing is typical with migraine headache. It's above her right eyebrow. Migraines tend to be unilateral. Started about 20 minutes after the bright lines. Within an hour of the aura, we typically find the onset of the headache. Neuro exam is normal. She's photophobic. You ought to be thinking migraine headache. Are there any red flags in what we saw? There really are none for me. I mean, I think everything sounds okay. Are there any labs or imaging studies you need to order? The answer is no. She looks just like a classic migraine patient. So how would you treat her? Well, there are a couple of different ways we treat acute migraine headaches. In this case, generally when we think it's mild to moderate and they're not nauseated, we go with an NSAID. Maybe Toradol would be a good one to give, and or Tylenol. If they're nauseated, we got to treat the nausea. If the headache is more severe, then we often reach, at that point, for triptan. But NSAIDs are quick, they're cheap. If this is not what she's got, the outcome is usually not bad. So that generally is how we approach these patients, all right? And obviously there's more than one way to do it, but I want to make sure you've got those main points. Everybody with me? All right, so let's keep going. I'm changing gears. Vertigo. Vertigo is a trick. It's an illusion. It's the feeling that things around you are moving, but they're not. Maybe it's a feeling that you're moving, but you're not. So vertigo is an illusion. It's a trick. It's also not a diagnosis. It's a symptom of something else going on. And so when a patient comes in with vertigo, your brain is supposed to flip to the vertigo algorithm. Because here's what you need to discern right away. Is this person with vertigo have vertigo of central etiology, which means it involves the brain, I'm getting them out of this clinic? Or is it of peripheral etiology, which I'm probably going to keep? So how do you differentiate that rapidly? A good thing to do is this. These are the characteristics of peripheral versus central etiology. The safest and quickest thing to do is this one. You know that when a patient has vertigo of central etiology, something's going on in the brain. Heck, maybe they had a stroke. That's why they're having vertigo. They've had a bleed. That's why they're having vertigo. The vertigo goes on no matter what you do. When a person has BPV, benign paroxysmal vertigo, a peripheral etiology, by far the most common, 95 or more % of the time, peripheral vertigo is secondary to BPV. It's the one you've seen or maybe you've had. If you can get the patient to focus on an object without shifting their gaze, you can stop the vertigo until they shift their gaze or move, and then boom, it starts all over again. If you can get the vertigo to stop, you can keep them. If you cannot get the vertigo to stop by focusing either on the palm of their hand or on a distant object, they need to get more testing. You follow me? The vast majority of patients who come in with vertigo are going to have peripheral vertigo. The etiology is BPV. You can keep them. But if you cannot stop the vertigo, even with getting them to fix their gaze on a hand or a distant point on the wall, you've got to rule out that something central is not going on. You follow me? And the safest way to do it is to get them to focus. All right? So that, I think, will help you. Central vertigo always gets referred. Let's talk about peripheral vertigo, because the most common is BPV, benign paroxysmal vertigo. It's brief, it's recurrent, and the symptoms are reproducible, right? The symptoms are reproducible. Here is your first patient with BPV. She is a 44-year-old who presents with suspected BPV. She probably has, she better not have mild hearing loss. What might you think of? And it's not BPV. Meniere's disease, right? Ringing in her ears. If you have BPV, honey, you don't have ringing in your ears. If you have BPV, you have a positive Dix-Hallpike maneuver. You remember Dix-Hallpike? Oh, I only ever did it once in my life. And I learned a really good lesson. You know about Dix-Hallpike? You know how to do that? You get them to sit up like this. Okay, you finally get the vertigo to stop. Say, oh, look, I'm going to lie you down, Mr. Boudreaux. You lie down, oh, I'm getting nauseated. Oh, don't worry, Mr. Boudreaux, I need to do this Dix-Hallpike maneuver on you. You lie him down, vomit all over your shoe and pants. I only did it once. I'm not the smartest bear in the forest, but I'm not the stupidest one either. I did it once, I got it. I know how to do that. So now, you know what I do? Say, Mr. Boudreaux, you got that vertigo. Listen, Mr. Boudreaux, I don't lie him down anymore. Mr. Boudreaux, lie down on the exam table. So if he has to vomit, I'm out of his way, all right? So if she's got BPV, she's going to have a positive Dix-Hallpike maneuver, not negative, right? And then if she's got BPV, she probably will have nausea and or vomiting. Very, very common. So what's your best answer? It is number 4. You got it? She probably has nausea and or vomiting. The others, honestly, are red flags. They're red flags with vertigo. There's something else going on. How do we help these patients? Well, we used to write prescriptions for Antivert all the time. Antivert's available over the counter in the form of diamond hydronate, meclizine. Every pharmacy and retail pharmacy has a store brand. And what's the brand name for these? Dramamine, right? So Dramamine. So they help very much. And the benzos are like miracle workers. For people who cannot stop and vertigo will not stop, a little alprazolam under a tongue is like a miracle. The world stops moving in about 10 minutes. Is that an off-label use of that medication? Do you know about off-label use? Don't do it. You'll suddenly become on state board's radar screen. So suppose you had to get that patient to an ER. Or maybe they have BPV and they've got to travel 60 miles. Somebody else is driving. They've got to get 60 miles to go back home. You might give them a little benzo under the tongue. How would you document that? Patient very anxious about next episode of vertigo. All right, so benzo, that's an off-label use, but man, does it work well. All right, peripheral vertigo, when it's BPV, keep them. If it's central, boot them out always. Neuropathy. When a patient comes in with neuropathy, man, is this common, and you told me it was in your diabetics, and you're exactly right. An example of a mononeuropathy might be something like carpal tunnel syndrome. We'll talk about that briefly tomorrow. But a polyneuropathy is way more common. And typically when patients present with polyneuropathy, they've got something else going on. And so take a look. Risk factors. The most common risk factors for development of polyneuropathy. What are they? Well, listen, I'm going to cut to the chase and tell you diabetes is one of them, and alcohol use or abuse is the second. 2 most common, what does that mean? You must get that information in history when a patient comes in with complaints of something like polyneuropathy. So let me make sure you know what clues to look for.